Think we are live.
Yes, sir, you're live. You can go now.
Good morning, all. I would like to take this opportunity to thank Dr. Srinivas sir and Gansham sir for giving me this opportunity. For the next 40 minutes, I think we will go through the syndromic polymerase chain reaction based diagnostics in sepsis. Why these new diagnostic methods? Because the burden of sepsis in terms of mortality, morbidity, and also the cost is huge. Growing up for about more than a decade as a trainee, we were taught whenever a patient comes in sepsis, we are supposed to start early, appropriate, broad spectrum antibiotics. To break this down, early because a delay in every hour in providing the correct treatment results in a decline in the survival rate and increases the mortality by 7.6%. So, this changed the whole scenario of how we look at patients with sepsis. But in our day to day lives, as we see, this may not hold good for sepsis, but it definitely holds good for septic shock, as we see patients presenting with delayed sepsis for more than 24 hours. And if we go by this statement, the mortality should be 100% by now, by then. So next is the appropriate. So when we talk about appropriate, to be more closer to the appropriateness, we tend to give more antibiotics. So there is an abuse or rather overuse of these antibiotics that go on. And broad spectrum antibiotics, which means that the broad spectrum is not, we're not specific in giving antibiotics to the patients. So these golden words probably helped in evolving different kinds of diagnostic methods. And because of this narrow window and these non-specific antibiotics, the patient outcomes are really poor, and also they help in the development of multi-drug resistance. Hence, we have a need for rapid diagnostic methods, and we moved from the conventional methods of detecting pathogens to the new rapid methods along with the drug resistance. These methods actually give results within 1 hour, apparently, but because of the logistics, probably within 3 to 4 hours. So our diagnostics tools actually shifted from conventional methods, which actually included the microbiological methods and the biochemical methods like CRP and procalcitonin. We shifted to our modern methods, which are molecular methods like PCR, real-time PCR. We have the surface-enhanced Raman spectroscopy and the Malditoff methods. We also have the detection of the antimicrobial resistance. And then we also have the advanced methods, biosensor methods, and point of care testing methods. But these would be for another day and for another speaker. So polymerase chain reaction-based pathogen detection methods allow target pathogen DNA sequence to be amplified. These methods are actually based on a fluorescently labeled probe with two primers, which amplifies the target DNA of a specific pathogen. Because the probe will bind only the DNA fragments of interest, non-specific products are not detected. This eliminates the need for post-amplification specificity, which is the specific step required in the conventional PCR methods. So we moved from the polymerase chain reaction PCR techniques, from that to a real-time PCR, and from there, from the monoplex to the multiplex PCR, which differs from the conventional or singleplex PCR in that it can detect and amplify multiple pathogen genome sequences and antibiotic resistance gene markers in the same sample. Multiplex PCR allows for detection of species specific, genus specific, or serogroup specific targets with a rapid assay runtimes of around 1 hour. Syndromic panels consist of the most common causative pathogens specific to the clinical syndrome. Example, in the respiratory tract like pneumonia or the meningitis or the gastrointestinal tract or the UTI, or even the infectious diseases that we see commonly in our country. These syndromic panels make use of multiplex PCR technologies and can be performed directly on clinical specimens. In conjunction with other clinical, epidemiological, and laboratory data, these assays aid in the identification of agents causing specific disease states. These are the different kinds of systems that are available in Europe and also in our country. Like we have the BD Max system, we have the ePlex from the Genmark Diagnostics, we have the BioFire film array, we have the Univero systems and Verigene systems and Extract technology. They all use the multiplex PCR technologies and also gives the results within 1 hour. The turnaround time for most of them is between 3 to 5 hours. So we come to the syndromic polymerase chain reaction panels in pneumonia. There are several observational studies which suggest that the syndromic pneumonia molecular panels in patients with pneumonia, whether it is a community-acquired multi-drug resistant or the ventilator-associated pneumonia, the diagnostic yield is increased and it leads to the reduction in time to appropriate antimicrobial therapy and decreases antibiotic consumption. As I told before, the broad spectrum antibiotics doesn't always mean that we are specific, and because of the increased awareness and requirement of the target specific therapy, we are more shifting towards the PCR techniques rather than the conventional methods. Rapid multiplex molecular syndromic panels, they facilitate early adjustment of antimicrobial therapy or targeted antimicrobial therapy. In severe community-acquired pneumonia patients at high risk for multi-drug resistant bacteria involvement or with shock, syndromic panels should be requested to guide antimicrobial therapy. In patients with HAP or VAP, testing with syndromic panels is recommended regardless of the risk of MDR bacteria involved or shock risk factors. Both the samples like bronchoalveolar lavage or high quality sputum samples or ET aspirates can be used in this. Molecular syndromic panels results should be reported quantitatively whenever possible. Quantitative results, example in terms of copies per ml, should be interpreted on an individual basis, considering factors such as patient clinical condition, receipt of antimicrobials at the time of sampling, bacterial load, and the number of detected targets. In patients with hemodynamic stability, when there is no shock and patient comes only in sepsis, antimicrobial therapy can be delayed until the PCR results are available, but that should not be longer than 3 hours. So our norm that we think that every hour delays increases mortality by 7% should hold true for patients who are in septic shock, or rather we should think that the source control should be the one that is increasing the mortality with every passing hour rather than only antibiotics. So this is the algorithm where we can use PCR techniques. When a patient comes with a severe community-acquired pneumonia, we can actually check for the urinary antigen for Streptococcus pneumoniae and Legionella. And when there are risk factors for multi-drug resistant bacteria, and there is a shock, then we actually request for a syndromic molecular panel. Early adjustment of antimicrobial therapy according to these results can be done, and final adjustments can be done once the conventional culture reports are available. There are two molecular syndromic panels that are available right now with us. One is the BioFire and the film array pneumonia panels, and the Univero hospitalized pneumonia panel. They are designed for diagnostic hospital-acquired pneumonia, the ventilator-associated pneumonia, and the community-acquired pneumonia in high-risk patients for multi-drug resistant bacteria. There are a lot of studies that has been done on these panels, but the number of samples that they have is very small. So we cannot conclude on the mortality benefit or a decrease in the length of stay of the hospital. But most of the studies agreed that the sensitivity of 91 to 100% and specificity of 87 to 99%, while the conventional methods exhibited this sensitivity ranging from 27 to 70% in comparison to the molecular diagnostics. Differences in sensitivity and specificity between the PCR platforms tested may have complicated their routine clinical adoption because of the too many options of these platforms that we have, and there is a differences in the sensitivity and specificity of these platforms. There is a complicated scenario where to send these samples, especially because of the logistic issues that are also involved. These techniques actually demonstrated strong concordance with standard of care diagnostics for included for included species with no false positives compared to the clinical symptoms or cultures. These assays, they reduce the median time to clinical interpretation, potentially improving patient outcome. However, they miss clinically important pathogens, including Haemophilus parainfluenza and fungal species such as Aspergillus. There are some panels which include even these organisms when we specifically ask for the fungal panels, when we are suspecting them in patients like immunocompromised patients. The use of pneumonia syndromic molecular panels must not replace the conventional methods, but rather they should serve as a complementary tool for improving the management of patients and decreasing the selection of antibiotics for the MDR bacteria. They only decrease our time of giving non-specific appropriate antibiotics for the patient and decrease the time and make it more target specific. So about the PCR reaction-based panels in bloodstream infections. While blood cultures remain the standard diagnostic method in many centers, they are limited by slow growth of the organism, especially in organisms like Candida, and the inefficiency in patients on antibiotics or those with fungal or slow-growing infections. Especially in invasive fungal infections, including candidemia, which are rising in the ICU, especially because of the oncological patients and the transplant patients due to factors like complex surgeries and prolonged antibiotic use. These panels are becoming more used. We have the specific rapid diagnostic panels. Testing enhances the pathogen detection and also improves the treatment timing. Different panels are available for diagnosing and phenotyping bacteremia and also candidemia. The T2 assays which are available, they utilize the miniaturized magnetic resonance technology. They enable the identification of microorganisms in direct blood samples. They are not universally accessible, hence we cannot use it in all places in our country. And these panels, they actually detect a very narrow spectrum of bacterial and fungal pathogens than what we see in the conventional methods. These T2 panels are also effective in diagnosing candidemia and can predict complicated cases when the positivity of this panel persists even after the 5th day. And this test actually have a very high negative predictive value for the microorganisms included in the trial. But the coverage of these panels is limited until we ask for a lot of panels together. And these tests actually demonstrate a higher sensitivity than blood culture in detecting pathogens. What kind of a sample can be used in these patients? Directly blood can be used, or also the blood sample which showed the positive blood cultures from the lab can also be used, especially in techniques like mass spectrometry, which is the MALDI-TOF, and the rapid tests for the resistant is also available in these techniques. In the rapid molecular syndromic panels, they are actually proved especially useful when MALDI-TOF was unavailable or inconclusive, such as in cases of polymicrobial bacteremia, gram-positive microorganisms, or yeast infections, when rapid resistance gene detection methods were lacking. So this is the algorithm for the bloodstream infections, where initially, whenever the patient comes with a bacteremia suspicion, we send a direct blood technique and the blood cultures are sent. There's a clinical samples depending on the possible foci that we are suspecting to be in that patient and the surveillance samples. If there's an availability of MALDI-TOF, then we send the blood culture samples which are actually positive for growth and use it in a MALDI-TOF, which again takes more time compared to the syndromic PCR techniques. Some of them actually directly send the blood sample to the PCR techniques, and this also has detection of antimicrobial resistance genes for many organisms, like even MRSA. In Candida also, we use the direct blood technique and also the blood cultures technique, and we also use biomarkers like beta-D-glucan whenever available in the centers. So syndromic polymerase chain reaction panels, whenever we see in meningitis, the meningoencephalitis is a severe neurological syndrome associated with high mortality and disability rate. 1 in 2 patients will actually require the admission to the intensive care unit, and experts, they suggest performing rapid molecular techniques in all patients when meningitis or encephalitis is suspected, particularly in those patients with admittance criteria in an intensive care unit. The sensitivity and specificity of these tests is very high, and although the targets among them are very varied. Some viruses such as enterovirus and also herpes virus, they exhibit lower sensitivity in these techniques. In cases of a negative results, but there's a high clinical suspicion, then it has been recommended to actually perform the targeted monoplex PCR techniques, especially with the herpes viruses. The interpretation of results for herpes 6, so herpes virus 6 should be cautious because there's a possibility of its DNA, it's being integrated into the chromosomes in 1% of the human population. In this sense, the performing of a viral load in peripheral blood can be helpful to avoid false positive results. They can provide information on the threshold cycle value and also the amplification curves through an additional application that they use in these platforms. The nosocomial infections in the central nervous system, like those from the ventricular catheters, may demand alternative strategies beyond these panels, like directly sending for the conventional cultures. The rapid molecular syndromic panel actually does not replace the standard microbiological tests. They attempt to identify the pathogen in culture and determination of antibiotic susceptibility. This is the algorithm for the encephalitis, where we send direct blood cultures first, and then they start antibiotics without waiting for the CSF, and then lumbar puncture is done. CSF can be sent directly for the conventional methods like the culture, latex agglutination test. The cryptococcal disease suspicion is there, then we can ask for a monoplex PCR also, and then we have a multiplex PCR where we see bacteria, virus, and also which is, if it is negative, then we still have a high suspicion for viral encephalitis, then we go for a PCR monoplex techniques like HSV1, 2, and varicella zoster virus, enteroviruses, and other viruses if we are actually suspecting them highly. Then not only these bloodstream infections or the meningitis or pneumonia, but we have used these kind of techniques in other samples also, especially in the gastrointestinal tract. But because most of the time the gastrointestinal diseases are non-specific and are actually self-limiting, usage of these techniques in such kind of a situations can actually lead to overuse of antimicrobials and an increase in the antimicrobial resistance. So we can actually use the ascitic or the peritoneal fluid, the bile fluid, and also the joint fluid in patients who have infections post-implants or post-surgeries, and also for the nosocomial CNS infections. We can also use aspirates from the abscesses or cellulitis and the bone tissue biopsies, and also the lymph node aspirates. The sensitivity and the specificity is actually comparatively much higher than the conventional methods that we actually send. What are the advantages of these results? These results are actually rapid. Their turnaround times are really fast. They exhibit high sensitivity and specificity, and they enable us in accurate detection of pathogens even at lower concentrations. Multiplexing capabilities allowing for simultaneous detection of multiple pathogens and antimicrobial resistance genes in a single test. The automation in these molecular platforms actually reduces the hands-on time and also decreases the number of staff that is required. And some molecular platforms are actually suitable for point-of-care testing, which will enable a even more rapid diagnosis at the bedside in these patients. Not only the advantages, there are a lot of limitations to these tests. A careful interpretation of the positive results of these rapid molecular panels is a very crucial one, as they may detect colonization and also molecular remnants because of their high sensitivity, especially in samples which are non-sterile fluids. So sampling is a key, and the interpretation should also include, because multiple organisms that are detected, sometimes they do not correlate with the clinical scenario, and the organisms that are detected are actually not the cause for the infection that is going on. So this actually highlights the importance of the diagnostic stewardship to differentiate between the infection and also the colonization. There are several molecular tests which may be susceptible to technical issues such as sample contamination or inhibition. There can be missed detections due to genetic variants or lack of correlation between genotype and phenotype for the AMR genes, which can actually affect the test accuracy. They may not detect all the pathogens relevant to a specific clinical scenario, potentially leading to a missed diagnosis. And these techniques are actually expensive and limited availability is limited. So in a country like ours, the usage is there in the metro cities, but in the peripheral states, these are actually not available. And the turnaround times are much higher compared to what we have here. And what are the challenges in using these techniques is in the we can use these things in a challenging clinical situations, especially in patients like the immunosuppressed patients. In this group of patients, actually, there may be a clinically significant pathogens which are not actually included in the panel because the coverage of many panels is limited. The sample that we send to them, it can be actually of a poor quality, especially when we are sending only the sputum and not the bronchoalveolar lavage. And the absence of clinical context justifying the test, especially when the patient is only having a tracheobronchitis, but we have sent the test and we have multiple organisms detected, and we extend antibiotics depending on this detection, and also with those patients who stay in the ICU for a longer time. So a few words about the diagnostic stewardship. Every single in vitro diagnostic test offered in the clinical laboratories requires clinical correlation. So this caveat has become more evident in the era of syndromic testing because we have several laboratories and several tests and several panels, including multiple pathogens that are being detected, which do not have any kind of a correlation with the existing patient infection. So the diagnostic stewardship is defined as to select the right test for the right patient, generating accurate, clinically relevant results at the right time to optimally influence clinical care and to conserve the healthcare resources. So clinicians should also refrain from testing asymptomatic patients, performing repeated testing owing to low assurance of the initial result, or for test of cure because it can significantly contribute to overuse without any benefit of the patient care. Especially these things are seen in patients with GI symptoms, gastrointestinal infections. Communication between the clinical microbiologists and the healthcare providers is absolutely essential to maximize the benefit of these test results in the context of the patient and also the background, and as the pathogens detected may not cause the infection that the patient already has. So to conclude, these diagnostic tools do not substitute or replace the traditional microbiology and the conventional methods that we use. Instead, they are only complementary and they reinforce it. These diagnostic tools are not indicated for patients who have recently had a positive or a clinically valuable microbiological test, simply for ruling out other potential pathogens. All these microbiological diagnostic tools need to be progressively evaluated in terms of cost benefit, influence on mortality and morbidity, and health related outcomes. In order to select the best diagnostic tool for any patient, we have to keep in mind the source of infection that we are suspecting. These diagnostic tools are not indicated for patients who have recently had a positive clinically value microbiological test, simply ruling out other potential pathogens. Implementation of a diagnostic stewardship along with the antibiotic stewardship is necessary in every hospital. Thank you.
Thank you, Navina. I think it is a crisp understanding of where we are in terms of the molecular diagnostic testing. We often feel that because our conventional cultures are negative, we resort to this kind of molecular diagnostics and we tend to react to them as the numbers come in. But what exactly is the true predictive value or the positive predictive value of the result versus infection? We don't get know. But in certain situations, like transplant, post-transplant patients, immunocompromised patients, difficult to diagnose diseases, or especially in samples which are intrinsically sterile, like the CSF or the joint space. There, probably the reliability and the predictive value of these tests is very significant and reliable and actionable. So it has to be tempered with a clinical judgment and the clinical situation in which the sample has been sent. It is going to be the future, a combination of conventional diagnostics, molecular diagnostics, mated to an artificial intelligence algorithm is probably the future of how AMS programs are going to be structured and implemented. So, Ghanshyam, you want to add something?
Nothing much, except for the fact that, as you said, one of the major drawbacks of molecular diagnosis is the inability to diagnose between a colonizer and infection. Since it picks up the genetic material of the organism, right? Even if you have dead organisms or dead particles, the PCR based or the molecular diagnostics can pick it up. So you will not know whether it's a actually current infection or a past infection. Something that we all kind of experienced during the COVID period, where you were getting repeat positive PCR tests for the COVID. So that is something that you need to keep in mind. And I'm not sure if we currently have the tests which can directly take the blood sample. I think we have, as of now, only those kind of tests where you initially have to get a positive culture on the blood, and that blood is further tested for the identification of the organism and the resistance pattern. I think those couple of points I thought.
Yeah. Okay. Thank you, Navina, for a good presentation. If you have any queries or comments on this talk, please do post them on the group from where you got the link from, and we will answer them at the earliest opportunity. Do join us again next week for another session on the Higgs platform. Register for the Higgs conference on 19th to 22nd of June and subscribe to our YouTube channel. Thank you very much. Have a good day. Bye.
Thank you.
Have a good day.